I call this meeting to order. Welcome to meeting number 15 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergency situation facing Canadians in light of the second wave of COVID-19 pandemic. Today's meeting is taking place in a hybrid format pursuant to the House Order of January 25th, 2021, and therefore members are attending in person in the room and remotely using the Zoom application. The proceedings will be made available via the House of Commons website. So you are aware, the webcast will always show the person speaking rather than the entirety of the committee. Today's meeting is also taking place in a new webinar format. Webinars are for public committee meetings and are available only to members, their staff, and witnesses. Members may have remarked that the entry to the meeting was much quicker and that they immediately entered as an active participant. All functionalities for active participants remain the same. Staff will be non-active participants only and can therefore only view the meeting in gallery view. I would like to take this opportunity to remind all participants to this meeting that screenshots or taking photos of your screen is not permitted. Given the ongoing pandemic situation and in light of the recommendations from health authorities, to remain healthy and safe, all those attending the meeting in person are to maintain a 2 meter physical distancing, must wear a non-medical mask when circulating in the room, and it is highly recommended that the mask be worn at all times, including when seated. And they must maintain proper hand hygiene by using the provided hand sanitizer at the room entrance. As the chair, I will be enforcing these measures for the duration of the meeting, and I thank members in advance for their cooperation. For those participating virtually, I would like to outline a few rules to follow. Members and witnesses may speak in the official language of their choice. Interpretation services are available for this meeting. You have the choice at the bottom of your screen of either Floor, English, or French. With the latest Zoom version, you may now speak in the language of your choice without the need to select the corresponding language channel. You will also notice that the platform's raise hand feature is now in a more easily accessed location on the main toolbar should you wish to speak or alert the chair. And I caution that I actually don't see that on my screen, so that may be a promise yet to come. For members participating in person, proceed as you usually would when the whole committee is meeting in person or in a committee room. Before speaking, please wait until I recognize you by name. If you are on the video conference, please click on the microphone icon to unmute yourself. Those in the room, your microphone will be controlled as normal by the proceedings and verification officer. A reminder that all comments by members and witnesses should be addressed through the chair. When you're not speaking, your mic should be on mute. With regard to a speaking list, the committee clerk and I will do the best we can to maintain a consolidated order of speaking for all members, whether they are participating virtually or in person. I would now like to welcome our witnesses. As an individual, we have Professor Ehsan Latif, Professor of Economics, Thompson Rivers University, British Columbia. We have Dr. Samuel Vessier, Assistant Professor, Department of Psychiatry and Co-Director of the Culture, Mind and Brain Program, Department of Psychiatry, McGill University. With the Hospital Employees Union, we have Ms. Barb Nitterpel, President, Ms. Georgina Hackett, Director, Occupational Health and Safety, Ms. Maria Dreyfus, Care Aide. And with the Kids Help Phone Organization, we have Ms. Catherine Hay, President and Chief Executive Officer. Each witness group will have 6 minutes to speak, followed by we will have a single round of questions once all witnesses have made their statement. I would also advise that I will be using these cards. This one is, I don't know if you can see that, but it's yellow, and this one is red. I will display the yellow one when you have 1 minute left, and I will display the red one when your time is up. Thank you, and we will now go to our witness statements. Professor Latif, if you please, 6 minutes.
Thank you, Mr. Chair. It is my honor to appear before you today. My name is Ehsan Latif. I'm Professor of Economics, Thompson Rivers University, Canada. In my talk, I talk about from the perspective of an economist. I have done a couple of research or few more research on impact of recessions and mental health in Canada. So I'll try to connect my research finding with the current situation and also talk about some policy issues. So an economic recession impacts mental health in a number of ways. The unemployed people suffer most because of financial stress and loss of social status. Employed people also suffer from anxiety and distress because they feel they can lose job anytime. The mental pressure during the recession period may lead to excessive drinking, smoking, and drug abuse. These unhealthy behaviors often lead to chronic health conditions like cancer, stroke, high blood pressure, liver cirrhosis. Mental health impact of recession may not end with the end of recession. Sometimes people may suffer for an extended period of time. Using large-scale Canadian data from the Canadian National Health Population Survey, I conducted a couple of studies on the impact of economic recessions on mental health, drinking behavior, and smoking. In one study, I found that unemployment rate had a significant positive impact on weekly alcohol consumption and probability of being a binge drinker. The study also found that the unemployment rate had a significant positive impact on number of cigarettes smoked by daily smokers. The results suggest that the impact of unemployment rate on drinking and smoking behavior is more pronounced for males than females. In another study, I found that the provincial unemployment rate had a significant positive impact on depression. The study further found that females, individuals with post-secondary education, individuals with college, university education, and individuals below 54 in age were more likely to suffer from depression from an economic downturn. So all these studies are use data from 1994 to 2009. So it's a past recession. So now I connect this with what happened here now. The recession due to COVID-19 had a disproportionate employment-related impact on Canada's service sectors, including transportation, restaurant, accommodation, and arts and entertainment. Females and young people were the hardest hit group as they predominantly work in the service sector. The other hardest hit group were visible minorities, new immigrant, and indigenous people. Among the employed people, essential workers and healthcare providers were very much vulnerable to negative mental health impact of COVID-19. In particular, the healthcare workers had a greater risk of exposure to virus, and they had to work in a very stressful condition. A recent study by Statistics Canada found that pandemic had impacted the mental health of all Canadians. However, the youth people experienced the greatest decline since the pandemic began. The study reported that study reported that women were impacted women were more impacted than men. The study also found that visible minority groups were more likely than whites to report poor mental health. The study found that those already experienced poor mental health before COVID-19 were impacted even more by the pandemic. Finally, the study found that substantial number of Canadians reported increase in the alcohol, cannabis, and tobacco consumption. Now, during COVID-19 period of physical distancing, virtual mental health service played a vital role in providing mental health care. The virtual mental health services allowed better access to care for people living in rural and remote areas. Young people who are avid users of the internet may find virtual mental health care more comfortable and attractive. However, many rural and remote areas lack access to quality internet access. Further, the marginalized group such as homeless people may not afford internet facilities. Some groups such as older people are not familiar with modern technology. For complex mental health problems, virtual care may not be enough. Patients may also need in-person care. In the coming days, we need to expand virtual mental health service. However, at the same time, we need to make it accessible to all groups, including people in rural remote areas, indigenous people, homeless people, and older people, older population. During pandemic, the government of Canada launched a web portal called Wellness Together Canada, focusing on mental wellness. This web portal connects to peer support workers, social workers, psychologists, and other professionals for confidential chat sessions and phone calls to deal with mental health issues. Thus, public funded was certainly helpful, but people may not be aware. Recent studies suggest only 11% of the people used online system. We need more research on the impact of this tool. People may suffer from pandemic-related mental health trauma for an extended period of time. For this reason, federal and provincial government need to work together to reduce financial and other barriers to access to mental health care. In 2018 report on mental health care in Canada, the Canadian Medical Association pointed out lack of resources devoted to mental health support. The report noted that Canadian people have significant financial barriers in getting access to physical, psychological support. The federal government can seriously consider this issue because in coming days, we have to focus more on mental health care and tackle this issue. So thank you, Mr. Chair.
Thank you, Professor. We go now to Dr. Vessier. Please go ahead. 6 minutes, please.
Thank you, Mr. Chair, members of the committee. It's an honor to be here. I'm Samuel Vessier. I speak as a behavioral scientist and professor of psychiatry who specializes in the study of the impact of screen time on mental health and in youth mental health generally. I also speak to you as a parent and as a professor who's very concerned for the mental health of our youth, as Professor Latif mentioned. Because there's little time, I want to specify the take-home message is that there are really two pandemics going on at the same time with almost diametrically opposed risk and protective profiles. So as we know, old age is by far the biggest risk factor for mortality and complications linked to the COVID-19 disease, but young age is the primary risk factor for poor mental health, but not for mortality and complications due to the COVID-19 disease. So in the acute early phase of the pandemic, I participated in a study led by Professor Rebecca Robillard at the University of Ottawa, where we surveyed 6,000 Canadians on pandemic-related stress, anxiety, and worsened mental health. I'm going to mention some of the risk factors that we found, and then I'll go on to talk about some missing data that would really help us identify at-risk populations and identify prevention strategies. So what we found is that the biggest risk factors for worsened mental health during the pandemic were, of course, pre-existing mental conditions, female sex, as Professor Latif mentioned, although it's important to point out that women are more likely to report mental health problems. Men, unfortunately, are less likely to report mental health problems until it is too late. We know that they suffer from significantly higher suicide rates, particularly in the context of economic recession, job loss, but also divorces, which we know family relations have often been very negatively impacted by the pandemic. We also found that alcohol consumption and drug consumption was associated with worsened mental health. Certain personality traits like extroverts and people who suffer from neuroticism. Interestingly, very controversially, we found that a very strong predictor of more COVID-related anxiety was left-wing political beliefs. The point here is not a partisan political point, it is an empirical observation. The understanding of the crisis has unfortunately been very polarized, very politicized, with COVID denying positions associated with the right, leading to a certain bias in the liberal media for more quote unquote alarmist perspectives, thereby perhaps conferring higher anxiety for people who are left of the political spectrum. We know, however, that this is a predictor. What else did we find? Also, poor family relations predicted worse mental health, less time spent exercising or engaging in artistic activities. We found, however, although we're still looking at the data, that socioeconomic status did not necessarily predict mental health in the way that we thought. We found that upper middle class and higher people, particularly younger people, often seemed to suffer from more anxiety. So it may be that people who are working remotely have a different sort of stress profile, perhaps worsened family relations. So that was an interesting finding, but we found that by far the strongest predictor was age, people under 40, people in their 20s, reported much worsened mental health. We also found that increased screen time and social media consumption, even reading political news, was associated with worsened mental health. I will point out that many of us in the mental health research community were already very concerned with the mental health of our youth prior to the pandemic, and that a confluence of risk factors, many of which associated with increased screen time, isolation, were cause for major concern prior to the pandemic and have been gravely accentuated. It would be very helpful for us in planning prevention strategies to have better public statistics on the incidence of suicide, of psychiatric emergencies, of drugs and alcohol consumption, and so on and so forth. So to conclude, because I really want to leave time for discussion, I could go on at length to shed more light on these risk factors. But given the really, again, diametrically opposed risk profile, it is important from a mental health perspective to find focused protection strategies and to restore opportunities for youth that we know are conducive to better mental health. Human touch, participating in collective activities, participating in community, religious aesthetic activities, finding safe ways for those who are not at risk to return to class, particularly for university-age populations, has become a public health emergency. So I think that's about the gist of what I wanted to present. I'll be happy to answer any questions. Thank you again, Mr. Chair and members of the committee.
Thank you, Doctor. We will go now to Ms. Nitterpel, President of the Hospital Employees Union. Please go ahead, 6 minutes.
Good afternoon. Again, I'm Barb Nitterpel, the President of the Hospital Employees Union, also known as HEU. Our union represents more than 50,000 healthcare workers across the province, including 20,000 who work directly in seniors' care. Now, joining me today is Maria Dreyfus, a care aide in Fraser Valley Long-Term Care Home, and HEU's Occupational Health and Safety Director, Georgina Hackett. So thank you so much for the opportunity to speak with you about the devastating impact COVID-19 has had on those working on the front lines of this pandemic, which is, in addition to everything that we've heard so far, for the general public. Healthcare work is largely women's work. About 85% of our members are women, and this workforce is also highly racialized. Our members were exhausted, stressed, and at a high risk of injury well before the pandemic. COVID shone a light on the very difficult working conditions in long-term care especially, and it has exacerbated this situation immensely. On March 7th, a resident at Lynn Valley Care Center in North Vancouver passed away from the COVID-19 virus, the very first COVID-19 related death in Canada. And since then, there have been hundreds of outbreaks in BC care homes. And the majority of the 1,172 COVID-19 related deaths in BC have been care home residents. We know the impacts of stress on mental health are cumulative. So 11 months of working long hours, short-staffed, in fear and in worry, seeing so many of their residents die and their coworkers test positive for COVID has taken a serious toll on our members' mental health. On top of everything else, our members in long-term care are working in a sector that has been racked by privatization and contracting out under the former BC Liberal provincial government, where wages and benefits vary greatly across the sector. It forces workers to hold multiple jobs just to make ends meet. In fact, 1 in every 5 workers in our care homes held 2 or more jobs in this sector. And while the province has leveled up wages as part of its public health order to limit workers to a single site, many workers still have inadequate paid sick leave. So a lack of access to decent paying jobs and an adequate sick leave is also causing stress for our members. And as we saw in the SARS outbreak 17 years ago, we are only seeing the very tip of the iceberg at this time. Mental health impacts can last for years. And our members are really struggling, and we are concerned about what the future holds for them, for their ability to retain workers in this sector, and for the impact on employee benefit costs. And Maria is here to tell you about her firsthand experience of being on the front line.
Good afternoon. My name is Maria Dreyfus. I am a care aide in a long-term care facility in BC where I have worked for 12 years. My facility has had 2 outbreaks during the COVID pandemic. The first one was in May and very small. The second one was in November when more than 150 people contracted COVID. 93 residents, 63 workers, 26 residents passed away. It is difficult to describe how very scary it has been for all of us working in long-term care during the pandemic. But when the big outbreak hit our site, it was totally devastating. Residents that we have known and cared for many years were dying. We are their care providers, but also their family and friends. So this was very emotional and stressful. I myself was tested positive for COVID-19 and had to self-isolate. There are 3 other full-time workers living in my household, and they had to self-isolate as well. My biggest fear was that I was going to pass this on to my family. What were we going to do if we all had to be off work? Fortunately, I had a very mild symptom and was eventually able to return to work. But not all my coworkers were so lucky. One of my coworkers who tested positive is a young mother, and she infected not only her husband, but also one of her young children. Another coworker who tested positive recently found out that she had already, after she had returned to work, that her internal organs have been badly damaged. This news was incredibly difficult for us to hear. We all cried when we received her text. This cannot happen again. A quicker response was needed. There's so much fear and anxiety. We needed better communication about the virus, about the PPE required to protect us to the fullest, and that we should all apply for workers' compensation benefits and not to worry about having enough paid sick leave available to us. Thank you.
Thank you, Ms. Dreyfus. We go now for Kids Help Phone, Ms. Catherine Hay, President and Chief Executive Officer. Please go ahead, 6 minutes.
Good afternoon, and thank you, Mr. Chair and members of the Standing Committee on Health for inviting us to speak here today. I'm going to start with a stark and sobering statistic for us all. Last year, Kids Help Phone conducted over 4,000 active suicide rescues. And research tells us that for every suicide, 125 people are directly impacted. So not only did we save over 4,000 youth in Canada, but we spared 500,000 people in Canada from traumatization, from grief and loss of a loved one who died by suicide. The reality of the first wave of the pandemic hit youth very hard. The second wave is just as difficult. The third wave is real. It's the mental health pandemic. I am here because mental health is one of the most significant crises facing young people today. If we do not find solutions, if we do not ensure young people can access support, we will lose multiple generations. The future of a strong Canada relies on the well-being of the youth of Canada today. For over 31 years, Kids Help Phone has been Canada's only national 24/7 e-mental health service for young people in French and in English in every province and territory. In 2020, we interacted and connected with more than 4.5 million people in Canada, from typically ages 5 to 27, but also adults. That's an increase of 137% from 2019. And I do want to remember that the clinical teams at Kids Help Phone are on the front lines 24/7 and doing a tremendous job, and it is taking its toll. In addition to being an essential service provider, we use real-time data to inform our decisions and the mental health landscape. We're the only mental health service in Canada combining clinical expertise with AI and machine learning for triaging to deliver better outcomes when young people reach out for support. And we see the impacts of COVID-19 every single day. Throughout the pandemic, conversations about grief increased, as did conversations about eating and body image by more than 80%, gender and sexual identity by more than 65%, isolation more than 50%, abuse more than 45%. The list goes on. I also want to take a moment to recognize that all youth in Canada, not all youth in Canada, are equally served by the system. The underserved, remote, rural, racialized youth in Canada do not have equitable access, which is why Kids Help Phone is so important in addressing this reality. We are especially worried about far-reaching effects on some of our most vulnerable young people, including Indigenous youth, Black youth, youth of color, youth in rural and remote environments, and youth identifying as LGBTQ2S+. We hear from them every single day. The percentage of young people reaching out about racism and discrimination to us doubled after the murder of George Floyd and the heightened social injustice. These young people are some of the most distressed texters that we get every day, second only to those who fear harm from someone in their own home. And when they speak about racism, they're also more likely to speak about suicide. We need to do more. Canada needs to do more so that these young people do not get left behind. And I think we all agree, it is clear, the impact of COVID-19 has been profoundly hard on people's mental health, youth in particular. At Kids Help Phone, it led to immediate record surges in demand back in March, and it has continued to this day. 4.5 million connections in 2020. Kids Help Phone faced enormous pressure to increase service, as well as grapple with uncertainty around our financial stability like other charities. We are grateful to the Government of Canada, who made a significant $7.5 million investment over 2 years in our essential services. That critical contribution ensured we remained open and service uninterrupted. Even with record-breaking demands, we did not go dark, not for 1 minute. Our work is nowhere near done. It will not be done when COVID-19 is a thing of the past, which we all hope is soon. Everyone would agree that Canada's mental health sector is somewhat fragmented and struggles to meet the growing needs of Canadians. This is where Kids Help Phone can add value. We are pioneers in virtual care, and we continue to expand our e-mental health platform to provide more youth with more seamless access to the continuum of virtual supports. And we will work with our partners in the sector and governments to continue filling the gaps. We are leveraging our data, Canada's only real-time data showing what young people are facing in their words. We speak to them every day. The reality is we all know that the state of youth and mental health was in crisis before the pandemic. It is exponentially amplified. And in closing, and as I've said before, and we all know, this pandemic will not come to an end when vaccines roll out, or even when the country returns to a new normal. There is no vaccine for the significant implications to our mental health. Canada must be ready to handle the long-term mental health effects of the pandemic, and Kids Help Phone is a trusted partner. Continued partnership between Kids Help Phone and the Government of Canada will play a critical role in providing e-mental health solutions for all the young people in Canada and leveraging data to better inform policies and health system solutions. This is imperative. The future of Canada is anchored on the well-being and mental health of our young people today. It is on us to write tomorrow for them. So you need to know that Kids Help Phone will always be there for the kids that need us. We will be 24/7 in every province and territory in both official languages for all who need us. So I thank you, Mr. Chair, and members of Parliament, members of the Standing Committee. Thank you.
Thank you, Ms. Hay. We will now start our questioning. We will have time for one round of questions. We will start with Mr. McGuire, I believe. Mr. McGuire, please go ahead. 6 minutes.
Thank you, Mr. Chair, as well. And I want to thank our witnesses for their presentations here today as well. Just to start off with the Kids Helpline, Ms. Hay, thank you very much for your presentation. These are pretty stark numbers, the 137% increase since 2019. I just wonder if you can comment on the emergency helpline that my colleague Tom Doherty has brought forward in the House. It'll be another opportunity to help in that regard. But your line is obviously you're pointing out the use of it, and just the fact that you've helped prevent 4,000 suicides. Can you just expand on the mechanism that's involved there?
Thank you very much for the question, Mr. McGuire. And first of all, I do want to acknowledge the importance of increasing access for anybody in crisis. So a 3-digit access point where Kids Help Phone would most definitely be good partners to through technology. It should not be the problem of someone in crisis to figure out where they need to reach out to. So we stand up partners with our colleagues for that. You talk about our active rescue protocols and process. Kids Help Phone is national. We have professional counselors in counseling centers now remote in Montreal, Toronto, and Vancouver, as well as remotely in every province. We also have over 2,200 active crisis responders every single month on our platform. I give you that background because it's not so easy to just call 911 for support, because we might be in Toronto and the person in crisis might be in Sioux Lookout. So we have an incredibly good relationship with the RCMP. That would be our first point of contact to connect us to local police services. I also want to point out that we need to do work in this country, and we are doing work on what is the right step for active rescues. It is not sometimes the right thing to do to send police into a highly charged environment in some communities where police might, it just might be not the right thing to do. So we're working in Saskatchewan actually right now with a pilot on wellness teams responding to active rescues. Thank you.
There's lots of cases where it's very important to make sure that you're sending the right people to a situation. You're absolutely right. I just wanted to touch base with Ms. Netterpel and Ms. Dreyfus. I want to thank you for your presentation as well. This is a highly charged area, and I noticed that Ms. Dreyfus mentioned the PPE required for this process. Can you just provide us with a greater ability, greater certainty about what the quality of PPE may be that the Liberal government is purchasing for frontline staff? And have you got any recommendations for the government in regards to a more thorough job of inspecting those shipments of PPE? And but you talked more specifically just about shortages. If you could just reply to that first.
Hi there, Mr. McGuire. Yeah, I'll just pass it over to Georgina as she's the expert in the OH&S field.
Well, thank you.
So to comment on the experience in British Columbia, one of the major challenges we found is that our long-term care sector is fragmented in terms of who owns and operates and runs those facilities. And so if you were working in a long-term care facility that was owned and operated by a health authority, there was greater coordination in terms of purchasing personal protective equipment and the standards that those came under. And then the privately run long-term care facilities and affiliate run facilities were left to source a lot of their equipment in the early days. We had experiences where we needed to escalate PPE delivery to some of these facilities during outbreaks where they were caring for COVID-19 positive residents without the equipment that they needed, or for facilities that had found a source from a supplier that wasn't meeting the standards required for healthcare, and finding that we were needing to even ship this by taxi to those facilities.
Yeah.
One of the things that kind of helped along the way is a centralized supply hub that the province has set up. But again, the time that it took for that to be established across all of the sector and all of the different owners and operators took a significant amount of time during the crisis.
I know that you're basically getting into where I was going with this. The government in the early days threw out the emergency stockpile of PPE that we had, and then had a plane load from of our PPE sent to China. And I know that there was, you've just made reference to the shortage of PPE in those early days. That caused a lot of stress and anxiety. I know right here in my own constituency, there were people phoning our office about that from frontline care people. Are you hearing any concerns for your members about shortages of PPE? You referred to the earlier ones, but where are we at now as well?
We have had concerns raised as most recently as November, where different facilities were trying to access supplies, masks, non-medical masks, medical masks from different suppliers, goggles and glasses, visors. It seems to have settled out in the last few weeks, but as recently as November, there were issues.
Thank you, Mr. McGuire. We go now to Mr. Fisher. Mr. Fisher, please go ahead, 6 minutes.
Thank you, Mr. Chair, and 6 minutes is probably not going to be anywhere near enough with this group of witnesses. I want to, first of all, take a moment to thank you all for being here. Ms. Netterpel, Ms. Hackett, and Ms. Dreyfus, please take back to your membership the thanks of all the people in this committee for the incredible work that you and your members all do. We're so very thankful. And Ms. Dreyfus, I'm so glad you made a recovery from COVID. It's so nice to see you here, and thank you very much. I'm going to go to Ms. Hay if I could. Your statistics were alarming. The work you do it's overwhelmingly impressive. So thank you. So I'm a father of 2 teenagers. During the first wave, when we think about the schools and the programs for youth were all shut down, I was so glad to see that we did invest over $7 million with the kids' health phone. So I also want to take a quick second to thank Tony Van Binen, because we wouldn't be having these conversations if it wasn't for Tony pushing so hard for this study. And it's so important, the pandemic within a pandemic. I'm sorry that I'm getting so long before I get to a question, but this is pretty important stuff to me. So we see a light at the end of the tunnel with vaccines, but we're so far from being out of the woods yet. I think about social isolation. I think about virtual only learning for students across the country. Lack of in-person activity. It's a major issue. It was a major issue before COVID. It's going to be a lingering issue long after COVID. And what can we do better to support this generation of youth right now and into the future?
Mr. Chair, if I could
yes, I think that was
answer.
to you, Ms. Hay.
Oh, okay, thank you. And thank you for that question, Mr. Fisher. I could not agree with you more. As a father of 2 teenagers, I'm a survivor of the teenage years, thankfully. What we are seeing right now with young people is an enormous amount of loss and grief. And my colleague, I believe at McGill University, talked about touch and the lack of in-person interaction. I think it is important to create an environment where virtual care, virtual supports, multiple different ones, because one size fits all doesn't fit anybody well, is integrated and seamless. I could not say that more about the seamlessness. And I think that it is critically important that we build a system for young people where they are not left behind. And I think that the work of this government and other governments across Canada focusing on mental health and young people. The time is now, and we cannot let them get far behind. I could give you a list of things that Kids Help Phone could partner with that would directly impact young people. But for today, I just want to implore this committee to make sure you push all of us in the sector and yourselves to make sure it's seamless and that we are not fragmented and we're not assuming that the gaps are small, because the gaps are large.
Thank you for that. This will probably run out my time, but as a parent, I think about this a lot because many parents wouldn't be able to tell the difference between a child just having a bad day or a child going through mental distress. You know, we talk about the virtual learning. We talk about Zoom life. We, as all members of this committee, live on Zoom. We live in rooms with bad chairs, and we live with, you know, bad lighting and bad backgrounds. But when we think about our children, this virtual learning is not working. I shouldn't say it's not working. Sometimes it's not working. My son did the first semester, but wasn't willing to go back for the second semester and won't go back to school now until there's in person, because they're missing out on that quality of life, that touch, as the professor said earlier. What are the signs that parents and guardians should look for when we're seeing a kid that may or may not, sorry, a young person that may or may not just having a bad day?
Hey, I think that's you.
Okay, yep. Fine, great. Thank you again for that question. I think that COVID, remembering that mental health did not begin with COVID. So the things that as a parent, as a teacher, community member that worked before are really important to put on the forefront now. Watch for a young person's change in behavior, more isolation, distress, or even over-amplification of cheerfulness could be an indicator. My best advice, it's Kathy Hay advice, not professional advice, is to be actively involved with your young person or a young person in your life. Watch what's going on. Don't assume everything is okay, because if you're feeling the stress of COVID, which we all are, I can assure you, young people are feeling it even more. And if I could put one final note forward for people in communities, please watch out for young people, because abuse is increasing. Kids are in homes that might not have been necessarily safe before, and where they would have got support would have been in their schools or community environments, which aren't available to them now. So keep your eye forward. Kids Help Phone does mandatory reports every day, and we work with young people and parents in those environments. So I don't know if that answered your question, but
excellent. Thank you so much. Thank you, Mr. Chair. I know my time's up.
Yeah. Thank you, Mr. Fisher. Nous allons maintenant à Monsieur.
And now, Mr. Thériault, you have the floor. Thank you, Mr. Chair. Thank you to all of the witnesses for their contributions to committee. You have shed light onto our search for solutions to manage this type of situation and this pandemic. Dr. Vessière, I would like to first address the issue of the psychosocial effects and collateral damage of the pandemic. Throughout our meetings, witnesses have highlighted this collateral damage of the pandemic, notably on the impact of the COVID pandemic, testing, surgery cancellations. So there is perhaps a secondary mortality rate because of COVID, or very serious impacts to health, and mental health impacts tied to collateral damage. Last week, I participated in consultation carried out by the government of Quebec, and it clearly said that one of the missing pieces of data that we need to face is the impact, the psychosocial impact of this on the mental health of families. Could you tell us a bit more about this and provide some data to inspire us and perhaps some solutions? Yes, thank you very much. If you will allow me, I will answer in English.
So as you point out, we strongly suspect that excess mortality has been a problem. Excess mortality in turn is likely associated with a further psychosocial or mental health toll on those families negatively impacted by missed surgeries, by increased mortality not related to COVID or related to cancellation of hospital services. The one dimension that is closest to my own area of expertise that I do want to speak on as well in terms of missing data is that there's a dire need for better evidence-based research on the impact of isolation, increased screen time, and virtual and distance learning on the psychosocial, emotional development of youth and on their mental health. So the last thing that I wanted to mention also in response to the previous question, what can we do to help our youth? We knew before the pandemic that the figures were alarming, our youth are in distress. There's a confluence of factors that contributes to the increased erosion of resilience among younger people. One of them is increased screen time. We know this from research. What I would like to implore for a government to do, because we cannot rely on big tech companies to do this for us, is to at some point treat screen time like a controlled substance, like tobacco, cannabis, or alcohol, substances that we know negatively impact development, and have clear evidence-based guidelines for its regulation. In the short term, we can also communicate those guidelines through family physicians, through our educators, for responsible screen time, responsible screen use. This, many of us in the community believe, is a public health emergency, and it already was before the pandemic. It is considerably worse now. Thank you. Merci pour votre question.
Quand vous parlez de lignes.
You're talking about directives. Could you give us perhaps a few indications, a few? Yes, directives for the responsible use of screen time. What do you mean exactly by the usage of responsible screen time in this context? There are people now, as you know, we are in a pandemic, and we focus on people consulting and virtually. I imagine that in your practices it is beneficial, but we also think that there may be disadvantages, and we're trying to see what are the differences when you have therapies virtually, the limits that you encounter by contrast to when you meet in person. What could you say regarding these perhaps guidelines? What are things that we should do to increase distance consultations? Will this bring about secondary effects?
That you know, the work, for example, that Ms. Hay does is wonderful. It is needed. There is in fact research showing that teletherapy can confer some benefits for some patients who might otherwise have mobility or accessibility issues. So it's important to continue to focus on these strategies. However, it's important to focus on prevention strategies as well. If we know that over a quarter of our youth prior to the pandemic required mental health care, this is a sign that our society is broken in some sense. So we need to focus on the strategies so they do not need those services. Of course, those services are great, but you know, hopefully people would be healthier. So less screen time, more face-to-face activity would be better, having good regulations for the amount of screen time on a schedule and the developmental schedule. So 0 screen time for youth under 6, and then up to 1 hour a day with supervision, but also have good guidelines on the kinds of content that people consume, the kinds of use. So for example, we know that active communication with loved ones with social media is good. It's associated with, you know, increased well-being. Passive, mindless scrolling of anxiogenic information is not good. So there's plenty of those guidelines, but unfortunately, as I expressed to the National Assembly of Quebec last week, most of the protective factors that we can recommend do not presently apply under the current public health guidelines, which we know are required to protect our vulnerable population. However, moving towards focused protection strategies, targeting different groups with different risk factors, where we know that young people really need these opportunities to connect, in particular in school, in particular in universities, has also become an emergency.
Merci, Monsieur Thériault.
Thank you, Mr. Thériault.
Mr. Davies, go ahead, 6 minutes, please.
Thank you, Mr. Chair. I'd like to thank all the witnesses for your powerful testimony. I'd like to direct my questions to the HEU. Ms. Netterpal, Ms. Hackett, Ms. Dreyfus, I'd like to thank you in particular for your fierce advocacy on behalf of not only your members and those working on the front lines, but also the patients that they take care of. And I'd also like to thank you for the service you're doing. You know, it's well known that north of 70% of the deaths in Canada due to COVID occurred in long-term care facilities, and it's your members and staff and employees who have been on the front lines of this, putting their health and their families' health at risk. So I want to thank you for the incredible work you've done and sacrifice you're making for all of our health. It's been said that the conditions of work are the conditions of care in the long-term care sector. And I'm just wondering, Ms. Netterpal, to you first, what suggestions you have for the federal government to help prevent a health human resources crisis that I think is developing as a result of pandemic burnout?
That is such a critical question. Thank you, Mr. Davies, for that. I have to say that, you know, right from the get-go, there's deep fragmentation that happens here in British Columbia. Hundreds of different collective agreements. Many facilities don't have any agreements whatsoever, and it changes from province to province. And the impact of COVID has been pretty wide-ranging, but regardless, has been devastating. So I have to say, we have to go to the basics. We absolutely need to have national standards across this country about working conditions and the caring conditions that our residents are living in. And that means that we need to increase the federal transfer funds to provinces so that they can provide, you know, that dignified, unrushed care that our residents desperately need. And of course, those transfer funds must be, you know, provided, but with accountability attached to that. That's absolutely imperative. We need to address the very basics so that when emergencies such as COVID and SARS and other instances come along, that we have the capacity to pivot as quickly as possible. On top of that, of course, we need to have, and I'm not sure if it's federal, provincial, you all need to figure that out, but we need to figure out how do we provide sick pay for workers. You know, we have in the public sector agreement, you know, workers get as many as 18 days a year for sick time. But in the fragmented long-term care sector, we're lucky if they have 5 to 7 paid sick days. One instant where they have even one single, you know, symptom of COVID can wipe out their sick bank. And then what do? We're putting them in an untenable position where they have to feed their family, but they can't afford not to go to work. And that's not okay, especially in this sector. So we need to have a strong sick pay plan, but also I think it's important to point out that new hires get none. So a new hire during COVID works alongside full-time hours, alongside a fellow worker. They're getting no sick time. So that's where we should really start.
Thank you. And you sort of anticipated where I was going next, which is my party, the New Democrats, have been calling for national standards in the long-term care sector and working in partnership with the provinces and territories, establishing minimum standards on minimum numbers of hours of care per day, increasing the wages and benefits of working conditions of everybody who works in the LTC sector, and similar things. And I'm just wondering, part of that is we're hearing back that there is a noticeable difference in terms of the working conditions and care standards in for-profit versus non-profit or government care homes. What can you tell us about what you're noticing in that regard?
Well, I think it's important to really point out the differences between the private sector and the public sector, where we've had significant contracting out and contract flipping, which was designed to drive the wages and benefits down for workers. So what that resulted in is a dramatic gap in the wage between the public sector and the private sector, as much as $7 an hour. And that's not even including the disproportionate impact on their benefits and pensions. So what happens is you have this recruitment and retention problem. And as I mentioned earlier, we had a crisis in long-term care long before COVID even started because of that significant wage gap. So again, this province has done a good job in the sense that they've brought the wages up so that everybody gets paid the same. But that is something that absolutely needs to stay permanent. But it's not just wages, all of the benefits, it has to be equal right across the board in the sector.
Mr. Davies, you're on mute.
Thank you. Sorry, Ms. Dreyfus, last word to you. What would mean the most to you and your fellow workers to increase the morale and your enjoyment and your feelings of protection in the sector that you work in? What advice would you give us?
Go ahead there quickly.
Yes. It would really mean a lot to us if we are able to do our job, direct care, without being rushed at work, and being able to spend time, quality time with our clients.
Thank you, Mr. Davies. And thank you to all the witnesses for sharing with us your time today, and of course your expertise and your all the labors of basically labors of love that you put in every day. I would also advise that if you have any further information you would like to offer the chair or offer the committee, that please do send it to the clerk, and that will be incorporated as well in our study. With that, I will we will bring in the next panel, so we will suspend. Thank you very much for everybody. meeting is resumed. So welcome everyone back to, as we resume the meeting number 15 of the House of Commons Standing Committee on Health. And the committee is meeting today to study the emergency situation facing Canadians in light of the second wave of the COVID-19. For the witnesses just joining us, I'd just like to remind you that you may speak in the official language of your choice. Interpretation services are available for the meeting. You have the choice at the bottom of your screen of either Floor, English, or French. With the latest Zoom version, you may now speak in the language of your choice without the need to select the corresponding language channel. And with that, I will introduce our witnesses. From the Camrose Women's Shelter, we have Ms. Nora-Lee Rear, Executive Director. From the Canadian Grief Alliance, we have Maxine Ratner, member, and Mr. Paul Adams, member. From Homewood Health Center Incorporated, we have Dr. Carlos Lalonde, Executive Vice President of National Medical Services and Chief of Staff. And from the Mental Health Commission of Canada, we have Ms. Louise Bradley, President and Chief Executive Officer. Witnesses will have, each witness group will have 6 minutes to deliver a statement. I will note that I will show a yellow card when you are at the 5-minute mark and a red card when you're at 6 minutes. And with that, we will start the statements, if you please. For the Camrose Women's Shelter, Ms. Nora-Lee Rear, please go ahead. 6 minutes.
Thank you, Mr. Chair, for the opportunity to address the committee this afternoon. The COVID-19 pandemic has created a spike in domestic violence, meaning an increased number of people seeking support. The need for mental health support for our clients currently surpasses what the current programming and staff can offer, and other counseling resources in the community often have wait lists or cost more than our clients can afford. Experiencing abuse contributes to many negative mental health outcomes, including depression, anxiety, and PTSD. The additional stress, uncertainty, and rapid changes of the COVID-19 pandemic puts further strain on the women and children using our services. Access to quality mental health care is an important part of individuals' journeys toward a lifestyle free of abuse. One of our main hopes is that by offering our services and increasing mental health supports for these women and children, it will begin to break the cycle of trauma and support the clients' transitions to safe and independent lives. Fostering positive mental health is beneficial for the community overall, as better mental health is correlated to better overall wellness and the ability to function within society. To this end, our organization took on a designing an evaluation to understand the qualitative changes resulting from our program. And the evaluation focused on individuals recognizing that they are not alone in the world or in their struggles. We used a thematic analysis to discover key findings, and we believe some of those findings are relevant for this discussion today. We chose clients who were active as of September 11th, 2020, providing a pool of 52 possible respondents, the majority of whom had become involved in our programs since March 1st of 2020. While safety from abusers is a key part of our shelter services, numerous clients also identified the women's shelter involvement as a form of suicide prevention. Often there is a deep sense of loneliness that accompanies leaving a relationship, even an abusive one. This, combined with the logistical and economic complications that most women face, compounded with the mixed messages received during COVID, has created the perfect storm for abusers to capitalize on. The shelters state that they are the safest place to be even during COVID, while public health messages lock down victims with their abusers, making it more difficult for someone in an abusive relationship to flee to a shelter during social isolation because their partner may be more closely monitoring or limiting their technology use. One interview said that through this program, I went from feeling like committing suicide to feeling like I had a lot of hope. They went from feeling helpless to feeling they were powerful with choices and independence. This increased sense of control led to greater mental resilience and the ability to move forward within adverse situations, even during COVID. Many clients expressed that they had gained the ability to take back their power. Before being involved in our programs, respondents could not speak for themselves or their children, but they now report coming back to who they were before the abuse. They went from feeling helpless to feeling they were powerful with choices and independence. One interviewee said, "Knowing I have help gets me through mentally." Another said, "I know that things get worse for me. When things gets worse for me, the women's shelter is always there." A number of respondents shared the difficulty of addressing misconceptions about abuse held in society. Those experiences included conversations with friends and families who were uncertain about how to respond to disclosures of abuse, and also who just didn't get it. The common theme that united these experiences was trying to explain abuse to those who don't get it. One respondent expressed, "It is very frustrating because within my group of family who are supposed to support me, someone will say, 'You're a liar, and that didn't happen,' or 'it wasn't that bad.' These frustrations range from the systemic level to the personal level and are particularly difficult for someone who is trying to relate the effects of abuse on their mental well-being when no one believes them." Respondents also described their own barriers to accessing services. Abuse can skew an individual's relationship to help, including feeling undeserving of a help or fearful that assistance will be withheld. Respondents identified a fear of being told no when asking for services, and one respondent was afraid to access human services as she feared it would be used against her by her abuser. The constant fear of what will be used against our clients is an ongoing reminder of the control abusers have, and COVID has exacerbated that. During times of COVID, the public, while hearing pervasive messages to stay home and stay safe for their physical and mental health, women also need to know that 1, shelters serving abused women and children are open and are ready to help. 2, that you don't need to come to a shelter to get help. As they have done throughout their history, shelters have been innovative in their approaches to reach and support women in their mental health. What COVID has done is shine a spotlight on the many cracks and fissures in the support networks that women need on their path to healing. And we know that we can make a difference in women's mental health as well as their children's now and in the very difficult times that we know are coming. Thank you.
Thank you, Ms. Rear. We go now to the Canadian Grief Alliance, to Ms. Ratner or Mr. Adams to give the statement for your group, please. Go ahead, 6 minutes.
Mr. Chairman, honorable members, thank you for inviting the Canadian Grief Alliance to speak to you today. We're a coalition of grief experts and more than 150 leading health organizations, including the Canadian Medical Association, the Canadian Nurses Association, and the Canadian Psychiatric Association. We came together last spring to ask all levels of government to turn their minds to the issue urgently, the issue of grief urgently in the context of COVID-19 and in anticipation of the deadly toll we have seen since. Almost every one of us has suffered grief in our lives, the loss of a mother or father, a brother or a sister, a child perhaps, or a close friend. As profound as our grief may have been, for most of us, what we suffered was the usual response of human beings to profound loss. For most of us, with the help of family and friends and the passage of time, we rejoined the trajectory of our lives, even if the ache of loss never entirely disappeared. But what the research tells us is that when grief is complicated, if circumstances prevent us from having the space or the support to grieve, it can transform into depression or anxiety, dependence or addiction, self-harm, or the thoughts of it. Today, we're suffering a pandemic of grief. Nearly 20,000 Canadians have died of COVID-19. The image of a nurse holding an iPad at someone's deathbed is now a familiar one. Robbed of the chance to be with their loved one at their deathbed, the grieving may have a funeral replaced with a Zoom call. Instead of a house filled up with family and friends, the grieving may have a frozen lasagna dropped socially distant at their doorstep. No hug, no touch, no lingering visit. Nowadays, much of this is also true of those who grieve for the 25,000 people who die in Canada in an ordinary month of heart disease or cancer or anything else. More than 2 million people, Canadians, are estimated to have been touched directly by death in their circle during this pandemic, and their experience is anything but normal. It's complicated grief, the kind that we know that can lead to enduring mental health issues. And specific communities are especially affected. Health workers exposed to a scale of suffering even they are unaccustomed to. The CGA also recognizes the generations of grief that Indigenous people carry as the result of colonization and structural violence, which is often overlooked in public health policy. Our existing system is not well equipped to deal with grief, in part because it is rightly not regarded as a form of mental illness. Indeed, mental health advice that is sound for those suffering from anxiety or depression may actually make matters worse for the grieving. The grieving need dedicated support that understands the nature of their grief and how to guide them. That's why we at the Canadian Grief Alliance believe it's time for a Canadian grief strategy whose aim would be to help Canadians avoid succumbing to enduring mental health challenges that will diminish their lives and take a toll on our society and our healthcare system. And I'll ask my colleague Maxine Ratner to take it from there.
Thanks so much, Paul. Specifically, we are proposing a three-part emergency-based response as the first steps of a Canadian grief strategy. First, Canadians need expanded access to grief services where they live. Grief services that were largely under-resourced before the pandemic are now bursting at the seams, trying to meet skyrocketing demands. In many parts of the country, there are long wait lists or a complete absence of grief services. Without sufficient grief services, the risks for mental health issues to develop will increase. Communities disproportionately impacted by the pandemic, including racialized and Indigenous communities, are also being disproportionately impacted by grief. Grief support services and programs led by and for these communities are essential. Second, we propose a national public awareness campaign to increase Canadians' understanding of grief and provide education and strategies to help Canadians grieving in isolation to cope. Such a campaign would also acknowledge our collective grief as a country. And third, Canadians have never experienced this depth and breadth of grief and loss before. We propose a rapid national consultation in the immediate term and dedicated research funding in the months to come that would allow us to better understand pandemic-related and affected grief. We have a model that would allow us to complete such a consultation within about 2 months, as we're very connected to organizations doing this work and engaged with diverse communities across the country. These emergency measures I've just outlined are necessary but not sufficient to quell the rising tide of grief and its anticipated medium and long-term social, economic, and mental health impacts on Canadian society. Current mental health spending does not include grief services. Grief is falling through the cracks. We urge you to implement a Canadian grief strategy that brings together federal government departments, provincial and territorial partners, and NGOs to build a coordinated, sustained, and evidence-based response to the growing needs of grieving Canadians. Grief cuts across the government's work in health and public health, from dementia to substance use, Indigenous communities, and children. We envision this strategy as having a lasting place within the framework of government. A Canadian grief strategy will help to prevent significant mental health outcomes for individuals, families, and communities across the country now and in the months and years to come. Canada has the opportunity to be a true leader by being the first country worldwide to commit to a grief strategy in the wake of COVID-19. On behalf of an ever-growing number of grieving Canadians, we urge you not to miss this opportunity. Thank you. Merci.
Thank you, Ms. Ratner. We go now to Homewood Health Centre. Dr. Lalonde, please go ahead, 6 minutes.
Thank you very much for this opportunity, Mr. Chair. The COVID-19 pandemic has contributed to an ongoing and expanding mental health crisis for Canadians and for the systems, institutions, and professionals that provide mental health care across the country. The mental health impacts of the pandemic are both pervasive and severe, and as always, the most vulnerable people are suffering the most. I trust that we all recognize the truth in those statements and that the rates of anxiety, depression, addictions, and other mental health conditions have been on the rise. Rather than reciting specific statistics today, I hope to advocate for practical, inexpensive measures that we can implement now to make a significant and sustainable impact on Canada's ability to address this mental health crisis and the ones that follow. While I am the Executive Vice President of Medical Services and Chief of Staff for Homewood Health, a national organization providing mental health and addictions care, I'm also a member of the Board of Examiners for the Royal College of Physicians and Surgeons of Canada. I'm actively involved in undergraduate and postgraduate education within the Department of Psychiatry at McMaster University. And I'm a practicing psychiatrist with extensive experience in frontline, inpatient, and outpatient psychiatry. With that background, I would like to speak about our frontline mental health workers. It's not just our systems, institutions, and resources that are stretched by the pandemic. It's our people. At home, these people have been facing the same stressors as everyone else over the past year. In addition, they have been responsible for supporting those in need of intensive mental health supports, while often being faced with increased risk of exposure to the virus on the front lines. The pandemic has thus created a situation where our frontline mental health professionals, physicians, psychologists, nurses, and other clinical staff, the people supporting our most vulnerable citizens, and our exhausted medical professionals and essential workers, are also burning out at record rates. The result is that there are fewer qualified mental health professionals left to care for a growing number of patients. This has led to significant gaps in care and more burnout. I see it every day. In addition to the overall shortage of these professionals, these vital resources are distributed inequitably across the country. These individuals tend to practice more in urban areas and in certain provinces over others. Concurrently, we are rightfully doing more to encourage people to seek help. Wellness Together Canada, for example, is serving thousands of Canadians and provides easy-to-access virtual and telephonic services within a stepped care model, offering anything from peer support to short-term counseling based on an individual's unique needs. Unfortunately, experience gained over the course of this pandemic has further highlighted what many of us already knew, that the needs of many individuals cannot be fully met within the current system, and there's critically limited access to higher-level mental health practitioners, specifically psychologists and psychiatrists. Across the country, the availability of psychiatrists is particularly limited. There's a desperate need for these professionals who are uniquely qualified to diagnose and treat those with more severe forms of mental illness through utilization of evidence-based psychotherapies, measurement-based care, and at times medications. So what can we do? There are certain things we can do from an organizational level, but larger systemic change and national support is needed. In the long term, we can commit to making historic investments in mental health, we can train more mental health professionals, and we can incorporate virtual care requirements into training programs. We can work towards these types of initiatives down the road, but we need practical strategies that we can implement now to address the current needs during this pandemic. I have 3 suggestions. First, we need to make it easier to deploy expertise where we need it by reducing barriers between provinces to make it easier for qualified mental health professionals to practice interprovincially. With clinicians and patients becoming increasingly comfortable with virtual care, a licensed practitioner should be able to help patients in Alberta, Ontario, and Nova Scotia in a single afternoon. Speaking from personal experience, even for a Canadian psychiatrist with full licensure in one province, the process of gaining licensure in another province is onerous and can take months. The process is similar for those in other disciplines who report through their own provincial colleges. I'm in support of the recommendations of the Royal College's Virtual Care Task Force report, which spoke of the idea of a pan-Canadian license. Second, along with increasing accessibility to secure virtual platforms, I believe we should provide financial incentives for those services which we need the most, specifically consultations and the provision of virtual care, particularly in the most underserviced areas of our country. I would also suggest that this incentive not be contingent on the use of a specific online platform, like OTN, as is the case in Ontario for physicians. Third, we can streamline the process for allowing foreign-trained mental health professionals to practice in Canada. Even highly experienced psychiatrists who have completed all of their medical education in the United States face significant obstacles to practicing in Canada. This process seems unnecessary and can sometimes take years to complete, all during a time when our national need for these professionals is skyrocketing. As a country, we need to take better care of the people working on the front lines of our mental health system. To help them help their fellow Canadians, we need to act swiftly to enhance our professional capacity and give those professionals the flexibility to practice where we need them most. If we can reduce interprovincial barriers, if we can increase access to secure virtual platforms and provide additional incentives for the most needed services, and if we can accelerate the process of putting qualified non-Canadians on the front lines, we will be better prepared as a profession, a system, and a nation to help the people who need our help most. Thank you.
Thank you, Dr. Lalonde. We'll go now to the Mental Health Commission of Canada. Ms. Bradley, please go ahead, 6 minutes.
Thank you, Mr. Chair and members of the committee for having me here today. It's particularly timely given that yesterday was Bell Let's Talk Day and raising awareness about mental health. 2021 marks the 11th year for Bell Let's Talk, and it has a very different feel from previous years. Partly, that's because mental health has been top of mind since the onset of the pandemic, and the numbers speak for themselves. A soon-to-be-released Leger poll conducted for the Mental Health Commission of Canada and the Canadian Centre on Substance Use and Addiction spells out some very real concerns. The number of people in Canada reporting strong mental health has dropped by 23%, a drop from about 2/3 of the population to less than half since last March. And while awareness may be higher, the extent to which people with substance use and/or mental health concerns are accessing necessary treatments and supports is not keeping pace. Just 24% of respondents with problematic substance use and 22% with current mental health symptoms have accessed treatments since March. So on the heels of Bell Let's Talk, I think we can agree that it's time for some strong action. Now, don't get me wrong, 5 cents a text adds up to important community mental health funding. But to truly put our money where our mouth is, we've got to be willing to invest the kinds of dollars that move mountains, quite frankly. That's why we at the Mental Health Commission of Canada were so pleased to see Parliament unify behind the need for a standardized national mental health crisis hotline. It may be one small step, but any journey begins by putting one foot in front of the other. Perhaps, though, there's a means to accelerate our progress. While old-fashioned thinking is one means to an end, we'll race to a place of mental health parity more quickly if we're willing to hit fast forward by leveraging technology, which has shown in many instances to be as effective as face-to-face interventions. But before we talk about virtual care and e-mental health, 2 game changers the Commission is strongly advancing, we need to realize that given the complexities of mental illness, there will never be one single adequate solution. We can't separate the mind from the body, nor can we divide mental wellness from the experiences that have formed each of us. As humans, we aren't made up of neat compartments that can be assessed and evaluated in isolation to each other. We tend to be a bit messy and complex, a mixture of biology and psychology, heavily influenced by social determinants of health, such as income, education, race, exposure to trauma, and the list goes on. The question of equity is going to be central to any truly meaningful progress. And that means shining a light on gaps and building the bridges to span them. From a dearth of culturally appropriate care to dwindling broadband signals in rural and remote communities, to tech hesitancy amongst seniors or lack of access amongst people living in poverty, We cannot expect e-mental health to hurdle systemic societal problems that need to be addressed at the root cause. That doesn't mean we should throw our hands up in the air. Quite the contrary. Take Wellness Together Canada, which has been just mentioned. It is built on a framework championed by the Commission and is an important example of how partnerships across jurisdictions can translate into meaningful services. Today, we can access free mental health support through online services. That was developed to meet a need, and this happened almost overnight. If we can accomplish that, a feat once thought impossible, even if imagined at all, in fact, imagine how bright the future could be. To date, 500,000 people have accessed that site, but we know the need runs deeper. Pre-pandemic, 1.6 million people in this country reported an unmet need for mental health care. Given the precipitous drop in mental wellness, I think it's safe to say that that need has only grown. Yes, it's true that symptoms of anxiety and depression and suicidal thoughts are increasing, but that does not mean that we must accept and echo mental health pandemic as inevitable. If ever there has been a time to knit a tighter safety net, it is now. Whether we focus on standardizing virtual care or investing in accreditation of mental health apps, there is a critical role for all of you to play as decision makers with the capacity to champion innovation. Our late board chair, the Honorable Michael Wilson, put it best when he said, there needs to be a significant funding earmarked for ramping up access to services, community care, and suicide prevention. But there must also be latitude for proving the sound economics of creative approaches. These creative approaches include leveraging new technologies to keep pace with our counterparts in New Zealand and Australia. And COVID has underscored the importance of mental health, highlighting the precariousness of our well-being. So I hope that you will engage in further collaboration and innovation, and we look forward to partnering with you in these initiatives. Thank you kindly.
Thank you to all the witnesses for your statements. We go now to questions. We will have time for one round of questions. We start with Ms. Rempel Garner. Please go ahead, 6 minutes.
I think I'm going to be taking her time.
Okay. Go ahead, Mr. Dantemont.
Thank you very much. And I want to start with the Grief Alliance for a moment, because Nova Scotia is the province I live in. And I know there's a number of us that are, of course, Nova Scotia based, Mr. Fisher, Mr. Kellaway. And I mean, Nova Scotia has been experiencing a lot of grief, whether it be through the Portapique murders. Recently here in Southwest, we've had 8 people or 6 people in a vessel. We just lost a couple down in our neck of the woods as well. So it's been a lot of, even beyond the COVID issue, it's been a lot of very public kind of grieving that's been happening, or a lack thereof. So I want to understand what a grief service might be, because we don't have it here. Without the community and a few community members coming together to bring families and groups together, I don't know what a grief service actually is.
Well, thank you so much for that question. So there are organizations definitely across the country, and I know there's a wonderful provincial bereavement lead in your province actually as well. People who have the specialty and expertise, who are serving people on the ground. I'm from Toronto, and I can tell you, places like Bereaved Families of Ontario, a lot of hospices offer bereavement support. And you're right. I mean, there's a patchwork of grief services across the country. This is an under-resourced area that really affects all of humanity prior to the pandemic. And so you can just imagine that this patchwork of services that's been there pre-pandemic is just, as I said, bursting at the seams because they are hidden. They're things that people don't know about or access until they're affected. When someone dies in a long-term care home, as so many thousands of people are doing across the country, there is no follow-up bereavement support. When someone dies in a hospital, there is no follow-up bereavement support. And I will say, as a proud member of the palliative care community, as a hospice social worker for the past 10 years, in most palliative care contexts, there is no follow-up bereavement support. Hospices are one of the sole places where that happens for about a year. But any grieving person can tell you that 1 year is not sufficient in many instances, and that with the immense amount of grief and loss happening in your province, that's what we're thinking about when we think about complicated grief. Complicated grief happens when a person, a community, a family experiences multiple losses in a short amount of time or a long amount of time. Loss upon loss gets amplified. And so in many ways, and I would never want to project onto your community, but I imagine there's some manifestations of complex and complicated grief because of these multiple instances of trauma and loss happening around you. And so those are the examples that we're speaking of. But yes, I can look at my list actually to see who we've got. Like Hospice Halifax would be offering bereavement support, but you're right, it's not like a grief service.
We're 3 hours away from that, right? So
yes, exactly.
It tends to be the challenge, right? And
exactly.
we don't. And since COVID's here, where we're not traveling like we should be, we're not going to get the services that we should be. So that's adding to it. In the 3-point plan that you do have, or the request that you have you gone to government? Because I'm going to guess it's a health issue, so each province is a little different. There's a federal component, but who have you gone to, and what kind of commitments have you gotten at this point?
We have been meeting with some MPs that have been open to that. One of my colleagues within the CGA has met with the Minister of Health in Thunder Bay. So I think we've been, all of us working off the side of our desks. This is a volunteer effort, trying to get attention for this urgent need. And I'm happy to have my colleague Paul add to that in any way, if that would be helpful.
Yeah, I mean, we've interacted principally at the moment with the federal government. We've been trying to get our message out through the media. But it really touched me what you were saying. I lost my wife 4 years ago to cancer. I was able to be at her bedside. We had a funeral, family and friends came. We were able to travel to be with other family. All of these things are denied people. And as you were describing in a situation of irregular, really profound loss, it's very difficult to imagine that people have the resources at their hand to get through these.
Okay. I know I'm running. I got a minute left here, so I wanted to go to Dr. Lalonde for a minute. When we talk about the transfer of doctors, locums, being able to at least transfer these experts from one province to another, does it not fall upon the shoulders sometimes of the self-regulated college, the college of physicians, what have you? How do we deal with that as a country when we have so many of these self-regulated organizations or colleges?
I think it's a great question that I don't have a simple answer to. It's something that I think it's one of the few benefits of the COVID situation currently is that it has increased a sense of community and collaboration across the country and between organizations and such. And I would hope that in this type of situation, this is a topic that's been spoken about for years. And again, even prior to this pandemic, there was talk about a pan-Canadian license by some.
Okay.
And it would require collaboration and communication amongst the different provincial colleges, whether we're talking about the College of Physicians for the various provinces or other professional governing bodies, to essentially communicate and collaborate. It wouldn't be that difficult because we already have to register most of our documents and most of our other qualifications online. And it would essentially just be a matter of the provincial colleges cooperating and coming up with some type of formula to be able to make this work, and it's something that could happen very quickly. Take a process that takes currently a couple of months and whittle it down to something that could take a couple of weeks or maybe even a couple of days, because the requirements are almost identical across all provinces, and it's these boundaries that we've formed over time that just need to be broken down to be able to provide the services to people that they need. And we do know that again, there was a survey last year for Canadian physicians that have said 90% that show that 90% of the doctors in Canada have said that it would improve access to care across the country if we were able to do this. And about 50% of those physicians would be willing to do locums in various provinces, and a similar number would be willing to do virtual care.
Okay, thank you for that, and thanks for all the presentations. You're on mute there, Ron.
Sorry. Thank you, Mr. Dantomo. We go now to Mr. Van Bynen. Mr. Van Bynen, please go ahead, 6 minutes. Mr. Van Bynen, your sound isn't working. If you could check on your headset, there's a button that may be a mute button there.
Is that working?
Yes, it is. Go ahead,
Okay.
please. 6 minutes.
My apologies. Thank you, Mr. Chair. I want to start off by saying that I will be sharing my time with my colleague, Mr. Callaway. Dr. Lalonde, thank you for joining us, and thank you for the important work that you do. My understanding is that you're providing support and health care support for many of our healthcare workers. And based on what we've heard earlier in the previous setting, it's a critical need. My first question is that we've already seen everybody spending a lot of time in projecting what our COVID virus cases will be. Is there any source of data that will tell us? We're all talking about how serious mental health is. And frankly, I believe the next wave is going to be much greater. And a big role for this committee is to identify the gaps going forward so that the government can respond. So is there any way that we can project that we can project the trajectory of mental health needs and mental health cases going forward so that we can start preparing now to have the resources that we're going to need?
I think there are ways, and I think some people are working on those specific projections. Again, we know that as the duration of this pandemic continues, we know that the rates of depression have increased further, the rates of anxiety have increased further. It's one thing to be able to deal with a stressful situation for a short amount of time, but we know that the cumulative effect of this type of scenario tends to continue to raise various rates of all sorts of different conditions. Again, we know that those that are most underserviced will probably be impacted more. Again, folks that already have concurrent medical and psychiatric conditions, folks that are already on the cusp of poverty, people that don't have access to those resources, people that are losing their jobs and don't have the financial resources otherwise. Those populations will continue to get worse, as is the case for all of us. However, again, proportionally, we know certain populations are likely to be more effective. Women seem to be a slightly increased risk over men at this point. Families with young children under the age of 18, those marginalized communities, racialized, and members of our LGBTQ community, people that are most financially impacted. We know what populations are at greatest risk. We know the rates are rising, and we know that with the difficulty to predict what's going to happen moving forward with this pandemic, we know that rates of various mental health and addictions conditions will continue to rise.
Many of the points that were raised was a pan-Canada data system, and if we could do that with respect to mental health as well, it would help us identify the gaps and the areas where the gaps are the greatest.
Absolutely.
And there's another wave I'm concerned about, and every year Canadians show symptoms of season affective disorder, or SAD, and with winter just starting and the post-holiday depression kicks in, we now have a pandemic on top of that. I know it's still early in the year, but is there any data so far that shows how this pandemic has impacted people who are experiencing SAD?
I think that's a good question, but it's very difficult to tease out. And truthfully, I haven't looked at the data of rates of that could distinguish between those two conditions. So again, we know that that many people do, particularly in certain parts of the country where the sunlight is far less, that the winter months are much more difficult. We know that for these winter months in particular, the rates are far higher than before, but it is difficult to distinguish how much of that is related to SAD and how much of that is related to the pandemic. Realistically, compared to last year, given all conditions, other conditions being the same, the rates are much higher and in relation to that pandemic. Again, I think it's important to, I think it's less important to tease out what the causation is, but recognize that the rates are higher, identify those in most need of treatment of severe depression, whether it's SAD or otherwise, and connect them with the appropriate resources, not only for counseling, but again, we need to go beyond counseling, because when you get to the point of meeting criteria for certain conditions, you need some more specific evidence-based therapies, including potentially a SAD light for some people, evidence-based psychotherapies, measurement-based care, and again, sometimes medications. But that requires the human resources to be available for those people to access.
Thank you. I'll turn this over to my colleague now.
Thank you, MP Van Buyden. I appreciate it. My question is to Dr. Lalonde. Homewood Health is a partner in the mental health portal Wellness Together Canada. So my question for you, or one of them anyway, is, has this portal been useful, and has it been a useful resource for people and people you work with? And my second question is, thank you so much for the 4 pragmatic areas to look at. I will need to call you or do a Zoom to unpack all of that, because I'm very interested in that.
Absolutely.
But if there is one area within the 4 to start, where would it be and why? Thank you so much.
In terms of the first part of your question, has it been helpful to I think people within certain organizations or nationally? I do think it has been helpful. I think it's been very helpful, and even simply looking at the number of people that have accessed this service. I can't give you the specific number, and I think Ms. Bradley mentioned earlier that it was over 500,000, and I believe it's actually closer to 800,000 or so at this point, but I could be mistaken on that. But we know that quite a number of Canadians have accessed that resource, and again, trying to provide the most appropriate level of care based on that individual's needs, whether it's connecting with certain online resources for education, ICBT, peer support, or up to 4 sessions of one-to-one counseling virtually. We know that many Canadians have benefited from the service, but we know that that can only go so far. Again, if certain people are having more severe conditions, that's when that service starts to be insufficient. In terms of what I would do first, again, I think in terms of what can be done right away, I do think that with the cooperation for the various colleges across Canada, I think that can happen very quickly and very suddenly increase access to a whole lot of Canadians to psychiatrists, to other physicians, to psychologists, to other mental health professionals, if we're able to break down those interprovincial boundaries.
Thank you so much, and I will be reaching out to you, and thanks to the witnesses. It's been very illuminating.
Thank you, Mr. Calloway. We go now to, nous allons maintenant.
And now, Mr. Thériault, you have the floor. You have 6 minutes. Mr. Thériault? I'm sorry, Mr. Chair, I didn't hear anything. And since there was no interpretation, I don't know what you were saying. Madame Bradley, if you would allow me. You produced an excellent document about cyber mental health in Canada. I'd like to make a broad comment. It said that happiness is found between your two ears in the way you perceive reality when you get up in the morning. And at the same time, through history, what the pandemic has revealed is that throughout history, mental health has and mental illness have never had the status of an illness like others. And so it was neglected in our health networks. And now it's coming back to haunt us because we're in a crisis. And what I understood from your presentation earlier is that we need to intervene and continue to invest and intervene upstream for mental health determinants and mental illness while encouraging our ability to make mental health issues reversible. There were issues before the pandemic, and the pandemic is making things worse, but we haven't, as decision makers and a society, the right to not once and for all. We need to avoid remaking the errors of the past, and this pandemic can allow us to review our priorities, and a society that cannot tolerate an individual in perfect physical health wanting to put an end to their days because they have this basic suffering that they have in their perception of reality. That being said, I'll continue looking at one of your documents, COVID-19 and suicide, where you highlighted, and I quote, even if history shows that the COVID-19 pandemic and the predicted economic recession may have an impact on the suicide rate, an increase in the number of suicides is not unavoidable, end of quote. So what I would like to ask as a question is this. What are you proposing to avoid the worst currently? And what would be the priority measures? What are the most pressing things that we need to do here and now to ensure that this avoidable increase does not materialize?
For your question, I will try and answer the various parts of it. Certainly, your initial comment about this being important to address upstream is critical. And with regard to historical events impacting mental health and mental illness, you're absolutely right on that one as well. And that stigma, while we have certainly gone a long way to reducing it, is still alive and well. And I think that that is impacting, in particular, structural stigma is impacting why we aren't making the important decisions that are needing to be made, particularly during
Excuse me, Ms. Bradley, could you lift your mic better?
Sorry.
Thank you.
Especially during a pandemic. And if I could reference a previous question in answering yours as well, is that with regard to the Wellness Together portal is based on a stepped care 2.0 model. And I want to point out that it was piloted in one province first and is now available in 3 others, including Nova Scotia. And that in that first province, it was shown to decrease wait times by 68%. And so that's a very significant number, particularly when you're looking at wait times in Canada of about 18 months for youth and adults. And, you know, and I agree that with serious mental illnesses, it does need to be dealt with differently. And there is a big concern that the pandemic is probably impacting a lot of vulnerable populations, but in particular, people with serious mental illnesses. There was a study that came out just this morning that showed that people with schizophrenia are dying more from COVID-19 than other populations. And I do believe that suicide rates are avoidable. The difficulty with suicide rates is that we don't have very good data. We know that approximately 4,000 people every year in Canada die by suicide. And those rates supposedly have not increased, but they haven't decreased either. And that, you know, in order to address suicide, we need to know exactly what is what the rates are to begin with. There is a community program to speak to avoidable suicides that is now being rolled out and piloted in 8 communities across the country with the Mental Health Commission of Canada. And a number of others are now joining that provincially. So it's a very complex question that you've asked, but I do believe that there are definite ways to ensure that suicide rates do not increase, but we do have to look at the plight of people with serious mental illnesses and chronic illnesses. Thank you.
Merci, Monsieur Thériault. We go now.
Thank you, Mr. Thériault.
Mr. Davies, please go ahead, 6 minutes.
Thank you. Mr. Adams, back in May of 2020, you wrote, we are social beings who crave social contact, human contact. These are being blocked during the pandemic and there will be fallout, end quote. Can you describe for us what that fallout is in your view?
Well, we know from the research that that complex grief, by which we mean people who are not allowed to grieve in the normal way, the natural way that those who are privileged to have family and friends and space and time to recover our normal lives. We know that that can tip people into more serious mental health issues. That can be suicidal ideation, it can be anxiety, it can be depression, it can be enduring features of mental health that make it difficult for people to recover their balance and to rejoin their community and their lives and their work and their family in the way that, you know, that healthy grieving allows us to do. And I can say, you know, just one of the places that helped me and our 2 teenage children when my wife died was a local cancer organization that had a bereavement group. Well, that organization, like many charitable organizations, has lost funding, donations, and they've been laying people off at a time when the need for these kinds of supports for people are greater than ever. So, you know, there are all kinds of things that can happen. And remember, too, that just because you lost someone close to you doesn't mean that you haven't also lost a business, a job, that you don't have the other strains of the pandemic, of the trying to work with children at home or going into a stressful or even a dangerous environment. So it's the complexity of pressures that are particularly difficult.
Thanks. And now, Ms. Ratner, in December, you co-authored an op-ed in iPolitics that said the following: 3 seasons into this pandemic, there has been no comprehensive government response to the growing crisis within a crisis of grief. I'm just wondering, have you received any reason or explanation from the government why it's been so slow to respond to this, I guess, foreseeable grief crisis that was warned about, you know, back in last May?
We haven't received a concrete response. I think there's percolating interest, but obviously lots of things to focus on for the government. And so, you know, the fallout of significant numbers of deaths maybe wasn't front and center back in the first couple of seasons. You know, we have spoken, we do know that Wellness Together was like a major response from the government around supporting kind of people across Canada with mental health. And we've met with leadership of Wellness Together who acknowledge the significant limitations of their portal around grief. And so we are kind of making inroads for different departments within government to understand this issue. The distinction between how to treat and respond to mental health issues like depression and anxiety versus grief isn't something that's necessarily well understood. I'm happy to elaborate on that if that would be helpful. But I don't know if that, yeah.
Thank you. I have limited time, but maybe we can follow up on that. Ms. Bradley, the Royal Society of Canada recently issued a report titled Easing the Disruption of COVID-19, Supporting the Mental Health of the People of Canada, which recommended that Canada increase funding for mental health services to at least 12% of the health services budget to respond to the longstanding unmet need that has been exacerbated by the COVID-19 pandemic. Can you please tell us what percentage Canada spends currently on mental health and whether you agree with that recommendation?
I do agree with that recommendation, and currently Canada spends around 7% of its health dollars on mental health. With the recent investments over the next 10 years, that will bring us up, if memory serves me, which it sometimes doesn't, to approximately 7.2%. And what we are advocating for, if we are going to aim for parity between mental and physical health, is that it needs to go to at least 9%, which is going to require quite a significant influx of dollars. But I would hasten to add that it's important that it's not just the amount, that it needs to be done with innovation involved in that, and different ways of providing services, some of which we've talked about. So thank you.
My last question to Mr. Lalonde. Mr. Lalonde, I often hear that the answer to addiction isn't sobriety, it's connection. And we know that in recovery, so much is delivered via peer support groups, 12-step programs, and other such very important recovery models. I'm just wondering what impacts you have seen or you can tell us about in terms of the recovery of people suffering from addiction, how that may have been affected by the COVID-19 restrictions.
Yes. So again, I think that is a very good point that many of our folks with significant substance use disorders very heavily rely on their community support, on their sponsor, on 12-step meetings, on other peer support meetings. There's something to be said about the physical presence and the environment that, of course, isn't able to happen currently. I am glad to share that many of these peer support groups are still meeting through online platforms, and I know many of our patients here at Homewood are still accessing these online platforms. But I have heard from various patients and people seeking out treatment for addictions that that it's beneficial, but not quite the same. So my hope is that as the stay-at-home order in Ontario eventually is removed, and we're able to get back into at least socially distanced groupings, that we're able to re-implement some of these important strategies in terms of those social connections, the peer support groups. But in the meantime, be able to take full advantage of the online platforms that are available to all of us.
Thank you.
Thank you, Mr. Davies. That brings our round of questions to a close. I'd like to thank the witnesses for all of your expertise and sharing your time with us, as well as your care and concern. That being said, I see that Mr. Van Bynen has his hand up to speak. Mr. Van Bynen, please go ahead.
Thank you, Mr. Chair. First of all, I want to thank the committee for pursuing the issue that we have just concluded. I think we've had a very extensive understanding of it and a very important study, and of course what I refer to as the looming silent pandemic. And I think what we've heard today reinforces that. What I think is important, though, is that we now take some time to consolidate what we've learned. And my requests, and in fact I move, that the committee instruct the analysts to prepare an interim report on the topic of the impact of COVID-19 on mental health of Canadians based on the 4 meetings held on this topic as part of the study of the emergency situation facing Canadians in light of the second wave of COVID-19. That's the end of the motion. I think it's important for us to sit down and take a look at what we've heard before it gets lost in all of the others. And there's an opportunity for the committee so wishes to do the same thing for other topics. But I really think it's important now that we consolidate and take a look at what we've learned and put together a report so that it can be a chapter in the overall study that we're undertaking as a committee.
Thank you, Mr. Van Bynen. I will actually ask the analysts if they want to jump in here and give us some advice on doing such a report, on whether they're what they require and so forth. So,
Mr. Chair, if I can just pipe in as a point of order really quick, you may want to let the witnesses go, as I see them still on here, and there's really no reason for them to be sticking around.
Absolutely. Thank you, Mr. Barlow. Yes, I would advise witnesses. Thank you so much for your time. We certainly welcome what you've told us, but we will be remaining to a little bit of committee business right now. So you may feel free to leave if you wish. Thank you.
Thank you very much.
Go ahead. So once again, I'm asking the analysts if they wish to step in and give us some advice on how to proceed here.
Well, I think writing an interim report would be very helpful. It would help to focus the committee on what they heard during those first 4 meetings, and it takes the study in some easier to consume bites. So I mean, we're fine to go ahead and start to draft an interim report. If the committee wishes, they could also go the way of each of the members submitting what they hope to be in the report. That could be submitted through the clerk.
You're muted.
Sorry. It's usually better that way. So thank you, Sonia, for the information. I see that Mr. Van Bynen, you have your hand still up, or do you wish to speak again? You're muted. Okay, we have next Ms. Rempel Garner. Go ahead, please.
The testimony that we heard from witnesses today was deeply impactful for me, to the point where, like, I'm sure some of my colleagues on the meeting today, Chair, were likely almost brought to tears. The impact of the pandemic is felt across political stripe, demographic in this country, and I guess I'm sitting here trying to manage news that the Moderna shipment of vaccines has been deeply cut today. We've got more restrictions on Canadian civil liberties with no end in sight. The EU is looking at trade restrictions on vaccines. I'm actually just trying to manage all this news. And what I don't want to have happen with an interim report is that the government uses that as a way to stall witnesses on vaccine delivery or the ministers in front of committee next week on vaccines. So I don't mind if the analysts want to start writing an interim report, but if this is what this committee is going to do, then they can expect the fact that we are going to be providing recommendations as a committee on vaccine delivery. We're in a national crisis. Like I'm just on a Friday afternoon with no makeup on, trying to absorb the fact that our country is not in a position to be receiving vaccines anytime soon. And what I don't want to have happen is that our health committee, the federal standing committee on health, in the middle of like essentially a wartime effort when we don't have vaccines, that we might be wasting meetings, deliberating like punctuation on a report that's not material to getting tools that is going to end this pandemic. So if that's the intention of the Liberals on this committee, it is a no-go for me, and it's a no-go for the Conservative Party. I don't mind if analysts want to start writing stuff up, because I do think that the mental health impact of the pandemic is fine. I'm going to look to colleagues, particularly on the NDP and from the Bloc, that if we're going to support a interim report on mental health, that the deliberations on the report would happen outside of the meetings that are scheduled on vaccines for the next couple of weeks, or over the break. If we wanted to deliberate a interim report on mental health, I would suggest that this committee do that over the parliamentary recess, not during the regularly scheduled meetings that are coming up on vaccines. This committee needs to work across political stripe to encourage the government and come up with like bold moonshot positions to get our country vaccines. You know, as I'm sitting here, my phone has just been blowing up today being like, when are we getting vaccines? And me going, I don't know. The government won't say. They say September, but it's not looking great. So that is, like, just bluntly put, that's my concern. I don't think we should be passive aggressive on this. I think, like, if the Liberals want us to be taking meetings away from a vaccine study, I do not support that. There will be no improvement in mental health of Canadians unless we get vaccines, rapid tests, therapeutics, and variant testing capacity to every Canadian. So I'm not sure if any of the rest of my colleagues have this opinion. I would like to hear it, but I do not want to take committee business or meetings away to be looking at punctuation on a report when we need to be getting vaccines to Canadians.
Thank you, Ms. Rempel-Garner. We go now to Mr. Barlow. Please go ahead.
Thank you very much, Mr. Chair. And Ms. Rempel said much of what I was going to say is, you know, I understand Mr. Van Bynen's motion here and what he's trying to achieve, but I don't think that this report should, you know, if the analysts have the time and they are able to manage that and they want to work on that in their own time, I can understand that, but that motion or that report should not in any way interfere with the ongoing study of this committee into what is now going into vaccines. You know, we've heard from the witnesses as part of the mental health study that one of the root causes of people's stress and mental health anxiety right now is, you know, not knowing when access to vaccines is going to be happening, you know, no home-based and rapid testing. You know, if we really want to address people's mental health, we have to give them some answers. And those answers right now, the most critical thing is vaccines and where are they and what is going to be the distribution plan. So again, I have nothing against Mr. Van Bynen's motion as long as that study in no way impedes on what this committee is going to be doing next into vaccines. And Mr. Davies may have a further point in the fact that, you know, the NDP's priority is going to come up after the vaccine study. So he may see that as equally as important as the Conservative members on this committee feel on the vaccine. But I agree in that mental health, the impact that on mental health as a result of COVID is immense and profound. We've all heard that from our witnesses. We've seen the statistics that have been released. We saw the suicide numbers from across Canada as a result of an order paper question released yesterday. And Alberta, in my province, was the highest, second highest in the country behind Ontario. So we understand the impact this is having. But the root cause, the number one priority with Canadians that I think all of us are hearing right now is vaccines. Where are they? And unfortunately, the news just keeps getting worse and worse and worse every day, where, you know, our Alberta Health Minister came out earlier this week saying we are getting 0 deliveries this week, and our delivery access from the feds, we've been told, will be reduced by 80%. 63,000 fewer vaccines are going to be provided to Albertans in this quarter. And that is just unacceptable, and we need answers. So, Mr. Van Bynen, I appreciate your push on the mental health aspect. I support that. But I cannot support this motion if it in any way impedes our study on vaccines. Thank you very much, Mr. Chair.
Thank you, Mr. Barlow. Mr. Davies, please go ahead.
Thank you. Yeah, it's hard to debate this specific motion after hearing such impactful testimony. But what I want to do is sort of broaden the discussion. We've been studying COVID since last February, and we heard a lot of evidence on a lot of subjects between February and now. And of course, with the prorogation that ended that evidence, and if my memory serves correct, we adopted all that evidence when we struck the new committee, and we carried on with our study. My concern is, as impactful as the evidence we've heard over the last few weeks on mental health is, we've heard a lot of impactful evidence on a lot of issues. And I'm concerned that selecting one issue out of all of the different subjects and important areas that we've heard and then to occupy the committee's attention on that one particular issue doesn't do justice to many of the other issues we have, and it kind of prioritizes one particular issue out of these things. I mean, I think a very strong case has just been made by Michelle and John that if an interim report were to be issued on anything right now, it probably should be on vaccines. And then the next thing. And so I don't think it does violence to anybody's position that all of these issues are important. It's just the real question before us is, in the middle of this report, in the middle of this study, do we really want to stop and isolate one aspect of it and then devote very precious and scarce committee time to that particular issue? So I think I can say at the same time, I think mental health is extremely important, but I don't know that it stands alone among all of the issues we're facing in COVID as being the issue that we should stop and focus on. With respect to Michelle's case, I always admire her work ethic. I think I'm starting to understand why she was voted the hardest working parliamentarian. I'm not as hardworking, I don't think. Actually, the truth is that we're really stretched. I mean, we have 2 committee meetings a week. I know some of us are on more than one committee. I'm also on the National Security and Intelligence Committee of Parliamentarians, which also meets 4 hours a week. Plus we have our caucus meetings, and we have our question periods, and we have our constituency work as well. So and of course, maybe it's my unique situation along with Luke, but we're just one on this committee. And so there's no substitutions allowed, and there's just the one of us. So I don't think the answer is to develop more meetings. That would be very difficult to schedule. So what I'm going to suggest is that maybe, and it's up to Mr. Bynan, but I'm wondering if you might consider withdrawing the motion and or tabling it, and we could reconsider this maybe after we've heard at least the first priority of each of the parties on this study. I mean, we've just completed the first theme, which is the Liberals chose mental health. Conservatives are choosing vaccines. The NDP and the Bloc's issues are yet to come. And I thought maybe at the end of that first priority, because we have 4 each, perhaps we can revisit this idea there. And maybe at that time, we could review the major themes that we've had, and at that point consider doing an interim report, which I think is not a bad idea. But perhaps we can pick 4 or 5 or 6 or 7 issues that we might want to select out of the many issues that we focused on over the past coming up to a year, and issue an interim report, but not just on one particular issue, but on several. And perhaps that would be a logical break time for us to kind of consider the wisdom of doing an interim report.
Thank you, Mr. Davies. Ms. Sadu, please.
Thank you, Mr. Chair. I just want to remind the committee, I think we scheduled the witnesses. There's no wish to, this is just to, it's 1 year work. We just want to, and it will take time for the analysts to do the report. And the ministers are coming. We are all willing to do vaccine study, and witnesses already scheduled for next week. Thank you, Mr. Chair.
Thank you, Ms. Sadu. Mr. Van Bynen, go ahead.
Thank you, Mr. Chair. Let me be clear that there was no intent to delay the study on vaccines. I think that's an important issue that I think we all want to make sure that we study. And so looking at options on how we might do this, I note that the analysts had indicated that this would be helpful for them. And going back over materials and things that we've heard a long time ago, it makes it difficult for us, I think, to capture what we've heard in these last number of meetings. And I appreciate, and I had in mind that if need be, I'd be quite willing to participate in additional meetings, as was suggested by Ms. Rempel-Gardner during the recess. That was a very welcome suggestion on my part, so that we could go forward, capture the essence of what we heard. And frankly, I think it's a good idea to do the same thing for vaccines and any of the other programs. So I think there's a real benefit for us to do it. And if we can find a way to make that happen without delaying our progress on the overall plan, I think we should seriously consider that. Thank you.
Thank you, Mr. Van Bynen. Monsieur Thériault, LAC, s'il vous plaît.
Oui, merci, Monsieur le Président.
Yes, thank you, Mr. Chair. First of all, I didn't receive the motion. Not in French in any case. That being said, it's concerning the methodology. We worked before prorogation, and the work, well, I didn't see any written notes on it, and I would have liked us to have a document, just a reference document to continue to inspire our meetings like we do for briefing notes. We don't need to get into a process of interim report or we just have for the first sessions that we had after a number of meetings that we would work by theme based on the priorities of the parties. I think that what was said earlier about before we all start working on a part of an interim report, I would have liked to just give an overview of all of the parts. That's one thing. But on mental health, it seems to me that the analysts could produce a document like they do briefing notes, a document that would allow us to continue to read it and we could learn more based on our schedule so that when it's time for us to finish mental health and then vaccines, we in the bloc were trying to set priorities that affected part of a pandemic that was not covered the first time by another party so that we're not redundant, because I don't want to devote 8 or 12 sessions to vaccines, in any case, not yet. And so we were open to everything concerning collateral damage and so on. And we're not announcing anything yet today, but let's do what was said. I don't think we want to be at the end. Perhaps there will still be an election period. We don't want to get lost in the weeds. So what is important methodologically is for us to have a document, a reference document that is a resume of what's been said, from which when we get to the end of the first round of 4 themes, we could maybe hold meetings on an interim report, and then we would have had the summaries for each of the steps, and then we could add things, and we'll stop taking an incredible amount of time because we've taken 7 sittings to set our methodology, and that's illogical. I am clamoring that for the work that was done before the prorogation should have a report or some kind of summary of what was written out of respect for the people who worked on it. We never discussed it. We never put that on the table. I understand that it's an emergency sitting, but that doesn't prevent us from receiving the information to shed light on our work and to make it more relevant in our questions. So it's clear to me that if the objective this afternoon is to, well, for the Liberals, Mr. Van Bynen absolutely wants us to have additional sittings to immediately work on an interim report. I don't agree with that. And what I propose, and I hope that it's clear, we each will have a round, and then at the end of each round, there will be a report by the analysts. Well, not a report, but a reference document that will help us work on an interim report. But for the moment, I think we need to manage it differently. Thank you, Mr. Thériault.
We go now to Dr. Pawlowski. Please go ahead.
Thank you. I don't think, in fact, we have disagreement over this issue. We want to get on with the vaccine study too. We're all in the same boat. Everyone in Canada is. I mean, we all have. My parents have been staying by themselves in their little house for the past, 4 weeks or something, not being able to see their grandchildren. My kids, there's an outbreak at the school. None of them got their vaccines. My colleagues in the emergency room, they haven't got their vaccines. We're all in the same boat. We shouldn't all be all rowing in different directions, and I don't think we are. The Liberals do not want this to impede getting on with the vaccine study. That wasn't, in my reading, the intent. I would have thought that perhaps the analysts could start putting together the material as we continue as planned with bringing the ministers here and bringing in the other people on the vaccine issue. And we're not being passive aggressive. I want to be aggressive. Bring the vaccine people here. Let us ask them the questions. Let everybody, let Michelle ask them the hard questions, because we want answers, and we're not trying to hide anything. So, and I want to ask the questions too. So, certainly that wasn't the intent, was to put off the vaccine study, because we all agree that is the issue, overwhelmingly the most important issue facing the country right now. Thanks.
Thank you, Dr. Pawlowski. Go now to Mr. McGuire, please go ahead.
Thank you, Mr. Chair. This is mental health issue has been on everybody's mind as well, but to help solve that, as we said earlier on, I think one of the best ways of doing it is to learn more about vaccines and when we're going to have them available. And so that, and as Sandhu said, the meetings have already been set for Monday, Friday, and going forward on vaccines, with the ministers coming in next week. And so I wouldn't want to do anything to disrupt, as Ms. Rempel said, the process that's going for vaccines. I know that it was a priority for Don's team as well, and I certainly concur with the comments of Mr. Davies as well. I believe he's absolutely accurate there in regards to making sure that we're not interrupting what's going on. I wouldn't even mind having that. I think it's a good idea to look at taking the first priority of each party and maybe doing an interim report at the end of that on those as well. But there is a need for each one of them perhaps to be done in a similar manner. But then we're breaking up what we said we would do in the agreement to start with, that we said we would have 2 studies, one on the Medical Prices Review Board and the one on COVID, which included mental health, vaccines, and the other issues, PPE and as such. So I guess the only thing I'd be concerned about is that we do have some, if there is going to be discussion on an interim report on mental health, that we look at it as taking some extra meetings, which I believe our colleague from the bloc just indicated, Mr. Luke just indicated that he was, and he can correct me if I'm wrong, that there was, he wasn't on side with that. But I would look at proposing some wording for an amendment, I guess, Mr. Chair, that any meetings related to the drafting or review of this interim report be held over parliamentary constituency weeks. We've got one of those coming up week after next. We already know what we're doing next week. If the staff there feels that they have the time to put towards this interim review on health discussions that we've heard very accurately from all of our witnesses, that any discussions we would have on that would be done during those, would make that as an amendment.
Okay, thank you, Mr. McGuire. That is so moved, although it kind of restricts our scope of action. It means we can't do add-on time to existing meetings. But anyway, that's your amendment. So the discussion is on the amendment. Ms. Rempel, go ahead.
Chair, I was just wondering if Mr. McGuire could clarify his wording for me. I was listening to it. I just wanted to clarify that what he was moving as an amendment was that the motion be amended to read that the interim report, the wording interim report be changed to summary of evidence for Mr. Theriault's suggestion, dating back before prorogation, and that any meetings relating to the drafting or review of this interim report be held over parliamentary constituency weeks.
That was not Mr. Maguire's amendment, as I recall. He was just adding that the request or the requirement that we deal with any meeting relating to review and approval of such a report during constituency weeks. His amendment did not change the nature of the report to be a summary of evidence. Mr. Kellaway, please go ahead.
Thanks, Chair. And some really good discussion happening here. And we started it off, MP Michelle Rempel-Gardner made some good points in terms of the heaviness of not just today, but this whole pandemic and how it impacts mental health. And it's personal for me on multiple levels. What I heard today just kind of reinforced a lot of things that I've seen in my own community and in my own family. But I want to go back to, I think, Dr. Lalonde, when he talked about kind of pragmatic and practical approaches to this. So again, being somewhat relatively new to this job, and I'm going to be able to say that only for so long, when we look at interim reports, and again, this is, I guess, on the elasticity of the analysts, but I'd personally be happy to do an interim report on the things that happened and discussed before mental health, but to look at ways to bookmark this, there'll be one on mental health and one on vaccines. Is that practical? Is that doable and whatnot? So it would be important for me. I've been an author of many studies. The worst thing that can happen is when you do a study and it sits on a shelf and it gathers moss. So those are a couple of the things I wanted to bring up. The other aspect of this is, we started off the conversation, and I'm paraphrasing here, but we don't want this to be a way for the Liberal members to slow down discussion on vaccine or meetings on vaccines or whatever the case may be. And that to me is such a, I'm trying to find the words here, and I can't really find them. That there is no way in any reality check that we would do that. Would anybody do that? Would anybody do that on this panel? Any party? To delay discussion on vaccines that is already lined up? My hope is that throughout these sessions, because it is wartime, that we sit down and again, we can critique the hell out of each other and our party stances on this. But I wonder if we can start with the practical first and then work to the political second.
Thank you, Mr. Kellaway. Monsieur Theriault, allez-y, s'il vous plaît.
Well, I think Mr. Maguire misunderstood what I said, and I probably misunderstood what he said, because on one side, I agree with what Don has said, and he agrees with what Don says, and there's an amendment before we've heard all priorities of all parliamentary groups. As Don had said, before we have an interim report, he's proposing an amendment that would go against this very idea. So I don't agree with this amendment. I agree with the idea that it would be interesting that the analysts give us a summary. And on that basis of this summary, we could work each on our side, then we'll study the vaccines, and we'll continue the study of the bloc and the sessions of the NDP, and then we can table an interim report. But we will have had a small document, not a huge document on which we'll work afterwards. We will have had these documents step by step so that when we get to this meeting for the interim report, we will have been able to save a lot of time. That's what I said. So if we have to have sessions next or meetings next week, or even before we touch upon another topic, I don't see the relevancy because I agree with Ron's position. We don't want to stop anyone from working. I'm not accusing the Liberals of anything. I take for granted that they are of goodwill. But I say that we have an interim report only once we have determined our priorities. Moreover, I'd like to mention that the motion that was adopted at the House is a motion that involves a COVID study in which we could propose some topics, namely, we started, for example, working on mental health, and we've done that, and now we go on to something else. And we'll be just as efficient in this interim report. So there you have it. This is why I don't understand Mr. Maguire's amendment.
Merci, Monsieur Thériault.
Thank you, Mr. Thériault.
Please.
Well, thank you, Mr. Chair. I can certainly agree with Mr. Telly more now than with Luke more now than I was. I'm much more clear on what he was looking at. But Mr. Chair, would it be possible to add 15 minutes to the next meeting and we could just have a separate part to discuss this at that time?
I think that would be possible if that's the will of the committee to do so.
I would make that as a suggestion, and then I would, we could discuss this further at that time.
I think what we're looking for there is a motion to amend to a date certain, which I believe is in order. If it's not, I will ask the clerk to step up. I think if that's your will, that Mr. Maguire, I suggest you make an amendment to, or sorry, make a motion to adjourn the debate until Monday after our witness testimony.
I would make such a motion.
Okay, is everyone in agreement with that? And I will go follow this guidance of the speaker and just look for negatives. Anybody who opposes that suggestion? Ms. Rempel-Garner opposes?
Not opposes. The motion is after witness testimony. I don't want that to be taken, this discussion to be taking over question rounds in the minister's time. So my understanding would be this would be like 15 minutes at the end of the next meeting.
Absolutely. There is no suggestion, there will be no suggestion of impacting witness testimony. Mr. Van Bynen,
that's not what I asked. It was question rounds after the witness testimony.
Mr. Chair, I believe that that's where we were going, and certainly what I wanted is to have the discussion here, the 15 minutes on Monday after our regular meeting is all over.
And that's absolutely how the chair interpreted it as well.
That's what I thought.
So
okay.
we have 3 people to speak, but we now have a new motion on the floor, a motion to adjourn. And that's actually, I believe that's non-debatable.
Non-debatable.
So we will have a vote on that. Is that the will of the committee to, and I will ask for dissent only. Anyone who opposes this motion, please indicate. Please wave at me.
Mr. Chair, could you please clarify the motion? Is this motion to adjourn now, or is this motion to move the debate to the 15 minutes after our questions on
the motion? The motion is to adjourn the debate now until a date certain, which will be following, the rounds of witness questioning on Monday.
Perfect. Thank you very much.
Okay. Again, I'll ask: is there anyone who dissents from this motion? Sorry, I'm seeing no dissent. Mr. Fisher, you waved at me. Is that dissent? I can't hear you.
Oh, sorry. I was thinking that this is something we could just do today. I mean, I'm looking for Dawn to come up with some suggestion to make this, I think Mr. Van Binen wanted was to maybe, and I don't want to speak for him, but maybe there's no terrible rush on this, that the analysts could be working on something in parallel to all of our studies, culminating the information, and then maybe a report comes out after. I don't know. I don't want to speak to Tony.
This isn't
Actually,
debatable, Mr. Chair.
Mr.
We're supposed to just be voting.
Mr. Fisher, it's maybe we'll just be a little more direct and ask the clerk to take a vote on this motion. So the motion is to adjourn this debate now until Monday, following the rounds of questions that are currently scheduled. So, Mr. Clerk, if you would please conduct the vote.
Mr. Fisher?
No.
Mr. Kellaway?
No.
Mr. Pawlowski?
No.
Ms. Sidhu?
No.
Mr. Van Binen?
No.
Mr. Barlow?
Yes.
Mr. D'Entremont?
Yes.
Mr. McGuire?
Yes.
Ms. Rempel Garner?
Yes.
Monsieur Thériault?
Oui.
Mr. Davies?
Yes.
Yes. So
thank you, Mr. Clerk. So the motion to adjourn is passed. So this debate will be resumed following the two rounds of witness testimony on Monday. Thank you all, and with that, we will adjourn the meeting. So thank you, everybody.
Have a great weekend.
you.